welcome to another production of Unfiltered Productions. Today, we're going to have some nursing real talk, and we have a very experienced home health nurse, Jean LaPadula, and I probably butchered the pronunciation of your name. It just came out wrong. Jean, tell us a little bit about you and your experience in home health.
Okay, thank you. And I'm so glad to be on the program. I'm a home health nurse for the past 40 years. And even before I started my nursing career, I was a home health aide for a local VNS company in New York. And I've done everything in terms of home health a nurse can do, from being the field nurse to being the supervisor, director of patient services, administrator, and the executive director. So in those 40 years, boy, have things changed, but have remained the same.
Well, I am so pleased and I know that our folks who listen to our podcast are going to be so happy to have a nurse on our podcast that has your kind of experience. I had an interesting thing happen this week. I wanted to start off with this, and I met a nurse who had been in nursing for almost 15 years, and the first 14 and a half of those years were spent in home health. And she was now a full-time nurse at a hospital on a med surge floor. And that's a kind of an unusual thing for nurses to go from home health back to the acute care. But so I asked her, I said, so tell me, are you enjoying nursing in the hospital? And she said she loved it, but that she really brought an interesting perspective, having been a home health nurse for so long, in that she realized that patients are not prepared well in hospitals to go home. And so she had a patient that had an infection, and they needed IV antibiotics, and they were trying to discharge them on a Friday. And she was able to change the course of care by saying, listen, you discharge him on a Friday, he may not get these antibiotics until Monday. And it was just an interesting conversation from that perspective. But most oftentimes we see that the opposite. We see that folks that have been in the hospital for a period of time, or skilled nursing, or a physician's office, actually end up going into home health after that experience, and they bring things with them into home health. Can you tell me what you think makes home health unique for a nursing clinician?
Well, most definitely. One of the most unique things about the home health field in terms of nursing is that you move from an area of specialization to being a generalist. So you need to have a wide experience and a wide base of knowledge in regards to different conditions and diseases. You need to be able to do everything from staple removal to wound care to patient education and teaching. You need to be somewhat of a social worker, somewhat of a therapist. So you really have to bring all your different skills and knowledge with you on every home visit.
So Jean, this is Cindy. With that diversity of skill set, and looking at the current situation where what we hear so much about is staffing shortages and the number of nurses that are now coming into home health, where it used to be kind of, I had all this experience initially in a facility and then I came to home health. Maybe it's not as much experience now, or it's the circumstances are driving more and more people into home health that don't have experience. What do you think that impact has been in terms of the ability to be properly oriented and to understand those kinds of expectations you just talked about?
Well, I think that many agencies are in such a rush to get the newly hired nurse out into the field that we forget to educate them and orient them to more than just what the medical record looks like. It's what needs to be part and parcel of that nursing visit. Many of us bring bad habits, whether we've worked in home health before or whether we've worked in a different venue. We tend to bring what we know from those venues to any new situation. So if you're used to doing a focused assessment based on a patient complaint, say, because you're coming from an ER experience or a physician's office experience. You tend to focus on just what's going on at that moment. In home health, you have to step back and you have to assess or reassess every time you go in to see that patient a number of different parameters. So it's just not focusing on the wound. It's just not focusing on the patient's complaint for the moment. You have to broaden your horizon and basically do a mini assessment from head to foot, an environmental assessment, uh, review of what's going on with the caregiver, what is the caregiver doing at this point in time, etc., and then be able to synthesize this at at the end of every visit so that you can plan the next visit.
So, Jean, I'm having a little bit of PTSD as a therapist because I remember when I came into the home health space about 28 years ago, therapists were in so short supply. It literally was my orientation. The person who was supposed to teach me what to do didn't show up. And so they gave me an evaluation form, still on paper, and the patient's address and said, go do that, and then come back and we'll talk about it. And for years, I fumbled around in the home health space, especially looking back, because I thought I was doing stuff that I was supposed to be doing, only to find later that you're not supposed to do it that way, or there's a better way to do that. And do you think that contributes to turnover? Because I know for me, and watching some other therapists come and go fairly quickly, I think sometimes when you don't get the right setup and you feel like you're, for lack of a better word, inept, you quit because it just seems like it's too hard and you can't figure it out.
I agree 100% that when you start out and you are not given the appropriate orientation, you quickly develop frustration. And when someone is then critiquing your documentation or the work that you're providing, you're like, I mean, what's wrong with what I've done? So uh, the opportunity and the time that you put into orienting a new employee has such a return on your investment that I can't even begin to tell you how important it is to do a thorough and adequate job. So I'm sure you feel the same way.
Yeah, and we see some of the after effects of that. Like I said, of people that just are frustrated, or they make mistake, or they're told they make mistakes, but nobody really told them that was the expectation. And now we throw into it the current environment of the pandemic and where we go from here. And I think during that period of time, the last couple of years, even the quote seasoned clinicians, compliance started to take a back seat to crisis. And we can understand that. But what you and I are seeing now from very similar perspectives, whether it's nursing or therapy content, is what happened to the fundamentals. And this idea that we're not being scrutinized as heavily, or we haven't been audited in a while, and we're doing our best to take care of patients. What are your thoughts on this kind of cutting corners off the compliance piece, in order to get it done faster or manage more patients? At what point do you think that might come back to haunt us?
I think it will very soon be apparent that there's a focus back on compliance because remember, compliance breeds quality, and that's the connection. When you're compliant with the conditions of participation, when you're compliant with the state rules and regulations, those are there as a framework for quality. And so when you start to cut corners, the outcome is less quality care to your patient. So the bottom line is always patient care. And good patient care begets reimbursement. So you never want to cut those corners. And skimp on the basics in terms of whether it's your nursing care, the care that you're providing as a therapist, or even the care the home health aide is providing. You always need to check off the boxes of doing a basic assessment, following the plan of care, making sure that your education is individualized to the patient and that they get it. They get and understand what you're teaching them.
Jean, do you think it's interesting when you made that connection just now of compliance and quality, because I think quality has kind of gone off the reservation a bit with respect to it's about stars ratings, and now it's about value-based purchasing, that is how you measure quality. But do you think the emphasis on those things and the OASIS responses that drive them, and we have to make sure, we're filling that thing out correctly, has that negatively impacted some of those basics and compliance issues that you're talking about?
I think so. I think one of the issues are we are very focused on completing the OASIS correctly. The OASIS is the basis of our assessment so that we can identify our patient's needs, and we build from the OASIS the plan of care. So while we're focused on answering things correctly so we can maximize our reimbursement, we then need to step back and say, so what is the information? What are the problems that I've found? What are my clients or my patients' needs? And how am I going to deal with it? So there's a direct line or a link between what we find when we do the comprehensive assessment, which of course includes the OASIS, to the care plan, to the care that we're providing. And I don't want to not talk about the goals and the outcomes, because it's the goals and the outcomes where we find the quality. I can write a beautiful plan of care, and I can write a beautiful summary of goals and outcomes that I want, and they can meet all the bells and whistles, being measurable. But if I don't connect all these separate parts, and for nurses, when I say this, it's going to ring the bell. It's part of the nursing process, from assessment to care planning to implementation to evaluation. That's the golden thread that goes through everything, and that's what underlies clinical quality.
Jean, you're just those things are so important. And I see that time and time again where you write beautiful pieces, but this isn't cohesive. And it's like you're missing what are we trying to do for this patient, and what does this patient need from us? And I think that people that don't sleep with the regulations under their pillows like you and I do sometimes think that those are all burdens and negatives and something that someone in the office is supposed to keep track of. I mean,
Right.
that really needs to get down to that front line in a way that says this is about patient care. Because I don't know what you're seeing. I see a lot of, anytime it's mentioned to be a rule or a condition of participation, it comes across as negative, like it's one more thing Medicare's making you do. Do you have any thoughts on that?
Oh, well, definitely. When I first started in home health, um, the whole premise of conditions of participation was foreign language to me as a home care nurse. I don't think I learned about those until I was 2 years into my career in home health. We didn't even have OASIS back then. And our plan of care was a pink piece of paper called a Briggs form that, had nothing to do with what I was doing when I went out to visit the patient. But over the course of time, you've come to realize that there's a direct connect between all of these components. The conditions of participation, which sets the framework for how we operate in home health, the things that are required to ensure that we're providing as a home health agency, along with the staff and any partners we have, that we're providing quality care. And so while we see all of those things as a burden, they're really the underpinnings of good care. Just like in a hospital, just like in a clinic setting, all of those, that's the structure that that we operate within, that says these are the things that we have found over time that a home health agency needs to have as part of their operational plan that will lead them down the road to quality care. However, if the clinician themselves doesn't recognize the value of the comprehensive assessment, which drives care planning, which then drives the plan of care, and which is a roadmap for the day-to-day care that the team is providing, then we're lost. Because after years and years and years of reviewing clinical notes, where I'm like, okay, yes, I see the nurses doing the wound care, but what about all this other stuff? What about that we said that the patient is going to be able to do this? So not only are we hitting the goal of getting this wound healed, but what about the fact that to heal a wound, you have to have good nutrition? Where, oh, where did we address that in all of our visits? Or that the patient has to be mobile and out of bed. Where did we assess what they're able to do on a day in, day out basis besides sitting in their chair on top of this wound? So yes, and that's one of the things about nursing is the ability or the knowledge base to step back from what you're seeing when you're going in and you're doing the assessment and understanding how it impacts on your goals. So that one, are your goals appropriate for this patient? Are there barriers to reaching these goals? And what can we do with that patient and their caregiver, if they're the caregiver, to reach those goals? So all these things have to get connected. And that's what each and every nurse learns during their education, the nursing process. So it's not these things happening in isolation, but that there's, and I called it the golden thread before, there's the thread that runs through everything that we do.
Jean, I have to tell you that is such music to our ears. You know, we for so many years have been out preaching and teaching and trying to get folks to understand that the process is cumbersome because the patient situation is unique. They're in their home, they're in their environment that they created, they're in an environment that they created that may not be safe, it may not be tenable. And I did not hear you say one time, Jean, that you click every goal that the EMR gives you and place it on a plan of care. I did not hear you say that.
No, your goals and your outcomes need to be individualized to that patient.
Oh, thank you so
Me.
much. Thank you so much for saying that. That is so I have pups in the background that you guys may be able to hear, so I apologize. I think that they are witnessing Jean at this point and all the things that she told us and the golden thread. I wrote down a couple of things that you said, Jean, because compliance breeds quality. It just sings to me. So I just want to thank you so much for joining us for your inaugural podcast on Unfiltered Productions. And I have about 17 ideas for more. But I wanted to wrap up today so folks can get to their next patient, and hopefully they got fired up by your knowledge and experience and your ability to really simplify it. We got to get back to the basics. We got to get back to the things we learned in school. We have to treat that patient holistically, look at their environment, encourage and teach and give them treatments that are going to get to those goals that you've individualized for that patient. I thank you so much, Jean, for being on our podcast.
You're very welcome, and I so enjoyed talking with you today. Have a good day.
Thank you, and we'll be back with another Unfiltered production. Thanks for listening.